One, two, three, start.
A very good evening to all distinguished colleagues. I'm Dr. Sameer Muchala, heading the medical affairs for the cardiology and diabetology therapy areas at Zydus Healthcare Limited. At the outset, I'm sure you and your loved ones are safe and healthy during this current trying times. It gives us immense pleasure to invite each one of you today evening to our live and innovative webinar on Best of ACC. The recently concluded American College of Cardiology virtual meetings offered the highest quality of scientific deliberations in the cardiovascular therapy area with state-of-the-art lectures. Zydus Healthcare Limited, being with academics at the forefront and a research-driven organization, takes pride today in presenting important updates presented at the ACC Virtual Congress related to hypertension and lipids, especially keeping the Indian perspective in mind. To enlighten us today evening, we have an elite speaker hailing from the United States, Dr. Benjamin Sirica from the Harvard Medical School. To moderate the sessions and the academic proceedings today, we have Dr. Ketan Mehta, who requires no introduction. It's my pleasure and privilege to introduce Dr. Ketan Mehta. Dr. Ketan is Convener, NatCon 2017, Vice President, IMA State 2015 to 16, Organizing Secretary, MasterCon 2015, Honorary Treasurer, ISC 2014 to 20, Honorary Joint Secretary, ICP 2013-14, Honorary Joint Secretary, NSphere 2010 to 18, Trust Board Member of the MMA 2013 to 18, Honorary Treasurer HSI 2004 to 6, President of the MMA 2009 to 10, Organizing Secretary of the Diamond Apicon 2005, Expert Panel Member MPOC, and Editorial Board Member of Journal of Medical Nutrition and Nutraceuticals. He's been affiliated to reputed institutes in Mumbai, namely Asian Heart Institute, Suchak Hospital, Nama Hospital, and Lifeline Medicare Hospitals. I invite Dr. Ketan Mehta and request him to take the academic proceedings forward. Thank you very much.
Thank you, Sameer, for the kind words. Good evening, everybody, and good morning, Professor Dr. Benjamin Sirica. It is indeed my pleasure to be amongst the elite crowd for a very important session today, that is Best of SEC. Friends, at the onset, I would like to thank Dr. Sameer Muchala and entire team Zydus, Vishwanath Kamath sir, Gautam Ghosh sir, and the full Zydus team for arranging such a fantastic program. Today being the 5th June, it is being celebrated as a World Environment Day. And this has been started since last almost 5 decades by obviously United States themselves, basically to create awareness about maintaining a good air quality and having a good environment. And now we have got a data that the air pollution which can also lead to cardiovascular diseases. Friends, but that's a very small subset. We know there is a large chunk which is coming from hypertension and dyslipidemia. And this is the data from Interheart study by Professor Dr. Salim Yusuf, who had shown that there are the factors which can contribute to a majority of extent, and where dyslipidemia and hypertension, which is contributing to very major extent. Friends, all of us know that American College of Cardiology, popularly known as ACC, which focuses on late-breaking science and interactive, innovative education to improve the cardiovascular cases. Every year, they have been organizing the conference, which is an annual event. Due to the COVID pandemic, this year, of course, the ACC 21, which was held virtually from 15th to 17th May. But believe me, friends, the attendance was probably more than what it would have been physically. In fact, I had the opportunity to attend few years back at Orlando when SEC was held, physical, and it was such a huge, gigantic conference. You need to be there to believe it, and the science which is delivered over there, which is absolutely par excellence. So again, in this ACC 21, almost 300 plus sessions featuring practice changing research and cutting edge education was discussed over there. In fact, I'm happy to share that one of my paper where I was the author, which was put in a poster presentation named as Triumph Study in this ACC conference. So friends, today what we are going to take is some of the best papers pertinent to hypertension and lipids, which will be discussed. That is how we have named it, Best of SEC Hypertension and Lipids. And to raise the curtain on this, we have none other than Professor Dr. Benjamin Sirica. Now, it is indeed my privilege and honor to introduce Sirica sir. Sir is a cardiovascular medicine specialist and associate professor of Harvard Medical School. He is currently serving as the Director of Innovation in Cardiovascular Division of Brigham and Women's Hospital. He's been a senior investigator at the TIMI study group. I'm sure, friends, all of you have heard of the series of TIMI studies and those well-known popular trial groups which has come, and they have almost more than 70 clinical trials in the field of atherosclerotic heart disease. To name a few, Sir has been the PI for Avantgarde TIMI 43, Camellia TIMI 61, Merlin TIMI 36, TRA TIMI 50, Saver TIMI 53 trials, so on and so forth. He has authored and co-authored more than 100 peer-reviewed articles in various international journals. He serves on the editorial board of Excel and is a reviewer for multiple international reputed journals like The Lancet, The Circulation, and the most popular Journal of American College of Cardiology, JACC. So it is my honor and privilege to welcome Dr. Benjamin Sirica, sir, please. And he would be talking about the best of SEC pertinent to hypertension and dyslipidemia. And he is predominantly going to focus on what is in pipeline, what we are going to see the future in the management of hypertension and lipids. It's over to you, Dr. Sirica, sir. Thank you.
Thank you very, very much for that kind introduction. I am humbled to be with you, Professor Ketan Mehta, on this panel. And I want to thank Zydus for supporting this symposium. Now more than ever, we very much need these types of events to be able to feel the community connection and to be able to share knowledge and share experiences. And I want to express my great respect and hope for all of the Indian medical community as they're fighting the pandemic. We obviously have had that same battle over the last year, and very much our hearts and our souls are with you as you and your families are getting through this. So what I'll do is I tried to choose a few topics from the ACC 21 that would, I think, build from some of the knowledge that we know about hypertension and lipids, and review some of the state-of-the-art talks that were done and combine them with some forward-thinking and forward-looking studies to see where we might be going. But always I want to really emphasize the foundation of what the therapy is we know we should do for these two very common conditions. So here are my disclosures. And let's start with hypertension. And I'm going to bounce a little bit between some recent publications as well as ACC. And I want to first just point everybody to a very recent review that came out in the Lancet on arterial hypertension. I think it's an excellent review. Everybody should look at it. It covers really what are the key components of what we know about arterial hypertension, and it compares the multinational societies and their recommendations. And it starts off again reminding us why do we use the drugs that we know work, the ACE inhibitors that inhibit angiotensin converting enzyme, the angiotensin receptor blockers that block angiotensin 2, the calcium antagonist, as well as the thiazide diuretics. It reviews what are the goals that we should have for patients, and they tend to be moving lower. And as data from SPRINT and other studies have shown, that lower is better. And then it looks at different recommendations of therapy, and we'll cover this a couple times, but it really does set on the foundation that we know the drugs, the renin-angiotensin-aldosterone inhibitors, A, the C, the calcium antagonist or calcium channel blockers, or D, the diuretics, really are the core therapy for managing hypertension. So A, C, and D. And the different guidelines and different institutes, whether it's the NICE in the United Kingdom, the European Society of Cardiology, the International Society of Hypertension, or the American College of Cardiology and the American Heart Association, all have slightly different flavors on this, but they really do always come down to let's start with the fundamental therapy of A, C, and D. Now, there was another paper that just came out that I also want to use as a background for what we're doing. And this is a paper that is published by the Blood Pressure Lowering Treatment Collaboration. And this is very much like the cholesterol trialist collaboration. And they were able to combine on a patient level the results of tens of thousands of randomized trials in hypertension. And they found a very important consistent finding that for a 5 milligram reduction in systolic blood pressure reduces major cardiovascular events by 10%. And that's irrespective of whether somebody has cardiovascular disease. And it's also even present at normal or high normal blood pressures. And this is one of those numbers I think we have to remember. 5 milligrams of blood pressure reduces cardiovascular events by 10%. And if you look for every 5 millimeter blood pressure reduction, you get this 11% reduction in patients with cardiovascular disease, about a 9% reduction in those patients without cardiovascular disease. And I think this is a very important message, not only for us in the medical community, but also for patients to understand. Now, what's the tragedy really in hypertension management is that we're not doing a very good job. And this is data that was shown at the American College of Cardiology from a United States cohort. And the truth is, not only have we never done very well, with our peak control being about 54%, we're actually getting worse. And this is a bit of a disaster from a public health standpoint. And the number of patients with hypertension who are taking their antihypertensive medicines, you can see in the United States, is still only in the 60% range. So we have a lot of work to do. And there are a lot of reasons for why we're not getting control. One thing that comes up often is how do we manage the more complicated patients with hypertension? And there was a wonderful review at ACC 21 by Professor Carey from the University of Virginia, where he gave some very, very useful tips and tricks and challenges for managing those patients with the most resistant hypertension. And he first reminded us what is the definition of resistant hypertension. That those people who have a blood pressure greater than or equal to 130/80, or an ambulatory blood pressure over 125/75, who are taking at least 3 medications of different classes, meaning A, C, and D, and are at their maximally tolerated doses and still are uncontrolled. Now, what is the key points of this? The first is the patient has to understand why their goal should be what it is. If they think 140 or 150 is good, then it's going to be very hard to get them down to a good blood pressure goal. It's very important when possible to use fixed dose combinations. That definitely reduces the chance of patients missing doses and not taking them. Substituting long-acting chlorthalidone or indapamide for hydrochlorothiazide is an important tip. Using amlodipine as a first-line calcium channel blocker is also helpful because the side effects tend to be very low. Monthly blood pressure visits, replace prescriptions with long 90-day prescriptions so they have a lot of it at their home. Use telehealth or connected blood pressure managements as possible. Screen for other reasons for resistant hypertension like sleep apnea, and in certain patients do a workup for resistant hypertension for secondary causes, and then really try to address as well lifestyle and medication adherence. In terms of the management of hypertension, this is a algorithm that he recommends, starting with a long-acting thiazide like chlorthalidone or indapamide, adding a mineralocorticoid receptor antagonist such as spironolactone or eplerenone. And that's where there's very good evidence. After that is where there's not as good evidence, but which I often do. I do like to add a beta blocker or a combined alpha or beta blocker. So that's either labetalol, carvedilol, bisoprolol, or I'll add hydralazine with a beta blocker and a diuretic in patients with very resistant hypertension. And then minoxidil is a combination of as well to use. So these are a little just sort of practical tips in terms of how to manage those most complicated patients with hypertension. What was also noted and reviewed was that medication adherence, which is a key part of blood pressure control, is often a surrogate for what patients like. And you can see that in the United States, 3 out of 10 patients with hypertension are not taking their medications. And that differs in a couple of different manners. The first is younger patients are less likely to take medications than older patients. Probably doesn't surprise any of us. Hypertension is called the silent killer because people don't feel it. And younger people feel like they don't need it when they obviously do. Fixed dose often helps more than non-fixed dose, but not by a lot in this study. The ability to get mail order, meaning their medicines were sent to them, improved the compliance compared to people who had to go and buy their medicines. And then ARBs in particular had a better adherence than diuretics. Again, something that's probably not surprising to any of us who are treating patients on a day-to-day basis, that when people pee a lot and urinate a lot, that can affect their quality of life. And what you can see on the right, even in some of the studies that looked at resistant hypertension patients, they found that up to 1/3 and even 40% of patients at different times in the studies were not taking their medications. And so really trying to ensure patients are taking their medications is probably the most important part we can do when we manage patients with hypertension. So what happens when somebody has resistant hypertension? Are there more options? And here I think was one of the biggest stories that came out of ACC 21. And that was the Radiance Hypertension Trio study. It was presented by Dr. Ajay Kurtain from Columbia University in New York, and it was published simultaneously in The Lancet. And this is the sort of perhaps most important of the ultrasound renal denervation studies, looking for patients who are resistant to 3-medicine hypertension. And this story of renal denervation is now pretty old. And there was a series of studies that were done maybe a decade ago that showed some initial hope, but then they had a lot of problems and did not show consistent results. And part of the problem was the studies weren't randomized and weren't sham controlled, meaning that some people had a procedure, but nothing happened. Sometimes the medication adherence was very poor. And and different between the two groups. And sometimes it just seems like they picked the wrong patient. But if you looked at the meta-analysis that was just published before this presentation was done, in those studies that actually did do sham placebo-controlled trials of renal sympathetic denervation, there is overall a signal that this procedure compared to medicines alone improves renal hypertension control, about 3.5 millimeters of mercury systolic and about 2 millimeters of mercury diastolic. And that's set up really for the objective of the Radiance hypertension study, which was the endovascular renal denervation. Their objective was to show that this procedure will lower blood pressure, and whether that can be done to reduce daytime ambulatory blood pressure in those patients who are resistant to standard fixed dose triple therapy. And the way this procedure works is a catheter is placed from the femoral artery up into the renal artery, and there is a ring of ablative energy about 1 to 6 millimeters that basically interrupts and destroys the renal nerve traffic. And that nerve traffic from the kidneys goes to the brain and increases the sympathetic nervous system and increases blood pressure. There seems to be little damage to the arterial wall, and it lasts just a few seconds each to each side. The way this study worked is it randomized, it first took people who still had blood pressures of greater than 140/90 on 3 or more antihypertension medicines. And so the first thing they actually did was start people on a calcium channel blocker, an angiotensin receptor blocker, and a diuretic. And to ensure that they actually had truly resistant hypertension. And they randomized people who still had elevated blood pressures to either renal denervation or a sham procedure, meaning they did the catheterization, but they didn't do any of the ultrasound. And they followed people both with home and ambulatory and office blood pressures over time at various time points. You can see that the patients tended to be in their 50s. They had normal renal function. About 30% had diabetes. About 20% had been hospitalized for hypertensive crisis. So this was a sick population. Few patients had heart failure though. And at baseline, blood pressures were in the office 160/100 on average. And at screening, you can see that some patients, everybody was on at least 3 drugs, some on 5 drugs. And you can see the classes that have been used, the RAS inhibitors, the diuretics, and the calcium channel blockers were by far the most commonly used in this population. And this was the primary outcome in the intention to treat population. They saw an 8 millimeter blood pressure reduction for systolic and for systolic blood pressure compared to sham. So a difference of about 4.5 milligrams of mercury. And in those who had complete ambulatory blood pressure readings, about almost 6 millimeters of mercury reduction. If you looked at it over the ambulatory blood pressure cuff, which is perhaps the best way to really assess somebody's true hypertension burden, you can see that the renal denervation was reduced significantly at 2 months. That's the green lines, and compared to the sham group in the blue lines. So very impressive, and reductions not only during the day, but also at night. And that continuous blood pressure control is important. Interestingly, that this looks at sort of the amount of blood pressure reduction people had. And there are some people who had some dramatic changes, certainly in the sham, but you can see that in the renal denervation, about 2/3 of the patients had at least a 5 millimeter mercury reduction. Half of the patients had at least a 10% of 10 millimeter of mercury reduction. And that's much lower in the sham. And that's just the percentage of patients on the right who had a blood pressure less than 130/85 at the end of the study. So the conclusions were that in patients with hypertension resistant to guideline-directed medicines, the renal denervation was better than sham for 24 hours and during the office. And these were at least supportive and help confirm some of the findings that have been seen below. I think we'll still have to see this, what are the longer term efficacy as well as safety, because what we really want to know, how does this look when we start looking several years after the procedure. There was an associated editorial in the Lancet that I thought was very well to the point. To our knowledge, the Radiance Hypertension Trio is the first trial showing blood pressure lowering efficacy of ultrasound-based renal denervation in patients with resistant hypertension. And in addition, there's been some real-world population with renal impairment and comorbidities where the blood pressure effects were durable over 3 years, which is beyond the timeframe of the control studies, but is supportive. Now, another I think important question and topic that's come up in the hypertension literature is do we have to be more precise or have more precision medicine when the treatment of hypertension? And it's good to define what is precision medicine. It really is the optimization of medical treatment based on an individual characteristics of each patient. And those individual characteristics may be genetics, which either is genetic susceptibility to disease or response to specific therapy, which is often called pharmacogenetics, whether it's environmental factors, and as Professor Mehta just talked about, air quality is one that is known to increase hypertension risks, behavioral factors, so diet, lifestyle, as well as other clinical factors, concurrent renal disease, sleep apnea, and then classifying patients into subpopulations that differ in susceptibility to disease, biology, and prognosis of disease may identify patients with better treatment. And the thought here is, again, if you look at traditional medicine, we give the same therapy to everyone. And on the left there, and some people benefit, some people have no benefit, and some may actually have adverse effects. The ideal precision medicine is that somebody, for example, gets DNA testing, and then based on that, they get tailored therapy for each individual patient. And so the idea here is that precision medicine incorporates individual patient variables to guide treatment decisions. Hypertension, unfortunately, is a polygenic disease, meaning there are many things that influence this besides genetic, and its behavioral and environmental factors. There have been incredible advances in genomics and information technology to allow this, but we really should focus in hypertension on not only the lifestyle and behavioral changes, but going back to those guideline-based pharmacotherapies. And if you look at the genetic architecture of blood pressure, for example, this is what's one way that people have expressed this, where each of these different areas around the circle are different genes that play a role in hypertension and blood pressure regulation. There are certain genetic conditions, Barrett syndrome, Little's, MEN, that have very well-known genetic influences. There are also the things like smoking, salt intake that also interact with genetics. It is very complicated. And I would say that the road to precision medicine in hypertension is still very long and winding. And for now, we just need to focus on the A, C, and D medicines to be able to control our patients with hypertension. I will now pivot and talk a little bit about the novel lipid therapies. And again, I want to start with our basics, what we've known, what we've learned now over 30 years in the cardiovascular prevention and treatment. And that really is that our primary goal in dyslipidemia really should be to treat low density lipoprotein cholesterol, LDL. And it has now been shown in multiple studies that the lower you get an LDL, the better somebody does in terms of cardiovascular outcomes. And as I mentioned, there is a cholesterol trialist collaboration that has demonstrated that for every reduction in 1 millimole of LDL cholesterol, you get almost a 30% reduction in cardiovascular events. And somebody's LDL goal really should be based on what is their atherosclerotic risk. And this figure from the European Society of Cardiology, I think, summarizes the findings and recommendations very well. That we first start with people who are at low to moderate cardiovascular risk. These are people in the primary prevention. You can do either the risk score that the European Society has validated in multiple populations. We also have the pooled cohort equations from the United States, but it will identify those patients for whom one wants to be more aggressive in terms of reducing their LDL. Below 100 milligrams per deciliter, you start talking about young diabetics. When you start talking about less than 70, we start talking about patients who have CKD, who have diabetes. And then in the very high risk, those patients with established atherosclerotic disease, whether it's by clinical or imaging, high score risk, strong family history, severe CKD, diabetes with organs, we're talking about very high risk where we're going to be aiming for LDLs that are at least 50% reduction from baseline and getting to levels of LDLs of in 1.4 millimoles per liter or into the 50s of milligram per deciliter. And to get to these levels, we really do need to very much utilize statins, especially high intensity statins like atorvastatin or rosuvastatin, and ezetimibe, which has very few side effects, but will lower the LDL by another 20%. And for a combination, for example, of using atorvastatin 80 and ezetimibe 10, which is one that I use a lot, you can get most people with greater than 50% reduction in their LDL and get to their LDLs into the 50s. And that is where we start seeing plaque regression, and certainly without any growth of the LDL. Now, it turns out that life for lipids is actually much more complicated. And Professor Vera Bittner gave, I thought, one of the best lectures I've seen in a long time in terms of the future of lipid management in terms of other novel pathways of lipid metabolism. And the important thing is that all of this that I'll talk about over the next few minutes is really based on the foundation of statins and ezetimibe. And then we have PCSK9 inhibitors as well, but these therapies that really do dramatically lower LDL. And these are new pathways where there may be some patients who would benefit from them. The first pathway and lipoprotein of interest is LP-little-a. It is a lipoprotein, little a as it's called. It has a couple things that are thought to make it a bit more high risk for cardiovascular events. First, it is highly homologous to plasminogen, which is part of the thrombotic or pathway. And there are oxidized phospholipids that can help promote or felt to help promote atherosclerosis. There have been a series of studies that have been done in terms of Mendelian randomization, meaning that they looked at different genetic variants that make people have higher or lower LP-little-a levels, and those people with the highest LP-little-a have highest lifetime risk. And they've also done work with other genetic factors where, regardless of how you look at it, whether it's population-based, Mendelian randomization, or genome-wide screening, higher LP-little-a does seem to be causally related to increased cardiovascular risk. There are very little therapies that actually can lower LP-little-a. So statins do not lower it very much at all. Ezetimibe does not. PCSK9 inhibitors can lower it some, but not very dramatically. And there's some patients, especially younger patients, who have premature coronary disease, but add other risk factors, where LP-little-a may be their primary risk factor. And there are now several therapies that are being tested in the phase 1 and 2 area in terms of lowering LPA directly. One of those is on the left, where you can see that actually they can lower LDL with different doses of this agent. It's the antisense oligonucleotide that targets the mRNA in the liver that makes LP-little-a and that reduces it by 80%. There's another agent called olpulsiran, which is a small interfering RNA target that, again, it stops the body from creating LP little a, and it too will reduce levels of LP little a. Now, here's just a quick slide to remind us actually how complicated lipids are, and just to track some of the different drugs and why we use them. Here's the gut on the right. You can see the cholesterol, triglycerides, bile acids in here. There are a couple different ways of blocking absorption of cholesterol. One is with bile acid sequestrants, which are not as well tolerated. Ezetimibe actually works on in this area by preventing the absorption of cholesterol into the intestinal walls by inhibiting a protein, Niemann-Pick-like protein transporter. When there's also a drug called lomipitide that blocks the transfer of these into the chylomicrons, which then become chylomicron remnants after lipoprotein lipase converts it. That goes into the liver, where through a variety, where the liver will then create cholesterol and metabolize cholesterol either through the HMGA-CoA reductase pathway, through the ApoB1 pathway, and will help break down or preserve it using PCSK9, a enzyme that will facilitate the LDL receptor destruction. And we block these in a lot of different ways. There's statins, obviously, that work at HMG-CoA reductase. There's bempedoic acid, which is above the statins in terms of that pathway by stopping the transition from citrate to acetylcholine. And then there are the drugs like inclisiran and the PCSK9 inhibitors that work on the pathway to reduce PCSK9. And then there are these inhibitors of lipoprotein lipase, the angiopoietin L3I, as well as that we'll talk about here in just a second. And what we've seen in Mendelian randomization studies is that there are known genetic defects or variants in different parts of the cholesterol pathway that can be specifically targeted by drugs. And these are the ones we know: statin, ezetimibe, PCSK9 inhibitors, bile resin or CETP inhibitors. And each of these variants will cause changes in LDL, in triglycerides, and in particular in LDL, and they lower the risk of coronary heart disease when you look over a lifetime. And so this is a nice way of trying to identify what are causal factors in terms of predicting heart disease. And these genetic variants seem to do that. And we fortunately have drugs that can try to perturb glucose metabolism to get that same benefit. Now, the same can be done when we're talking about the lipoprotein lipase pathway and triglyceride lowering. And here again, we have some of these different genes, the ApoC3 and angiopoietin TL3, where there are known variants. Those variants are associated, if they have loss of function, to lower risks of heart disease. And there are now some of these inhibitors, the ApoC3 inhibitor and the ANGPTL3 inhibitors, that are in clinical trials. And they have different names. Obviously, they're different companies, they're different mechanisms, but they can specifically target these different areas. And it's from both of these areas, and some of them do the ApoC3 pathway, some focus on ANGPTL3 inhibition. So a lot of new data there, and that we will be hoping for. But again, reminding everybody that this is all on the basis of what we know is that lowering LDL cholesterol, predominantly with statins and ezetimibe, is probably going to get most patients to the LDL goals they need to. And it's therefore incumbent upon us to try to educate patients to understand that and for us to prescribe those medications for them, in addition to the lifestyle and diet changes they should take. So I want to stop there and be able to provide time not only for some questions, but more importantly to hear Professor Ketan Mehta's comments and interpretations.
Thank you so much, Dr. Sirika sir. It was like indeed as if we are attending a real ACC conference 2021. In fact, you have started with the basic journey and the basics from hypertension and lipids and took us to the futuristic therapy in both the segments, be it hypertension or lipids. Now, before we start the discussion, first, let's take some interesting questions which has come up over a period of time. So obviously, we'll take certain relevant questions only. Of course, management of malignant hypertension, which you have already given one beautiful paper, which managing all the aspects. And you rightly said that, first we need to understand what is exactly the resistant hypertension, and then obviously sir has very beautifully given elaborately how to proceed about therapy aspects also. Now here I would like to just of course discuss with you, sir. In India, say for example, because of the tropical climates, the diuretics, they are one those who are already taking, especially the senior citizens, and they usually land up with a lot of issues with the orthostatic hypotension which is there. And that is how in fact we have seen that during summertime, like especially this, we have a summer from April, May, and June. So where the blood pressure, then they really feels the symptomatic, especially when they are standing and if they are on diuretic, and then we really need to cut off or take away the diuretic part also. And I'm sure that is not the case when we see because we see in Western population quite a huge number of patients who are on diuretic and they are tolerating very well. So you see this the difference on tolerability about the diuretics, sir?
I do very much. I mean, my usual preference when I start hypertension medicines is that I like to use an angiotensin receptor blocker and a calcium blocker, like amlodipine, felodipine, or even nifedipine extended release, for a couple of reasons. First, I think they have the least side effects. In most patients with normal renal function, there's very little concern about hyperkalemia or certainly not hypokalemia. And so I'm not worried if somebody doesn't come for their labs or they go away. And once joked, if somebody came into my office with very high blood pressure and was jumping on a plane to the Antarctic, a calcium channel blocker would be my choice of drug because I think that's the safest one to use. So I usually try to use those two drugs first and then add the diuretic in that case. And I think there are two components. There's some people who really just don't tolerate the diuretic because they do get hypovolemic. And that is, and I think you can try different doses and different types. Hydrochlorothiazide tends to be the least potent. Indapamide tends to be the most potent. Chlorothalidone is in the middle. And sometimes just a little bit of a dose, like a 12.5 milligrams of hydrochlorothiazide or 2.5 milligrams of chlorothalidone is all that it needs. And that doesn't cause the same amount of volume depletion as a higher dose. And but I do, especially for older patients, I do encourage them to continue to hydrate, especially in the summer. But I think diuretics are the hardest ones to tolerate. The other diuretic, that can often be very useful, is a mineralocorticoid receptor antagonist like spironolactone, which doesn't tend to cause the same diuresis perhaps, but can have a blood pressure effect because of its overall anti-aldosterone blocking on the periphery as well. For that, I do monitor the renal function more closely, but it can be a very good option if you are at 2 drugs, your A and C, and do need to add a D to your regimen.
Yeah, that's a very valid point. Extension to that, there is another interesting question from Dr. Renuka Devi from Gulbarga. Which would be the best antihypertensive in old age smoker? Is there any preference?
Mm-hmm.
Old age smoker.
An old age smoker. I mean, I think there are, I think the question is very important to highlight that there are features that make some drugs more appealing to in patients. And that is a little bit of the personalization that we do, even if we don't have genetics on somebody. And for example, somebody with diabetes should be on a RAS inhibitor to help preserve kidneys. Somebody who has angina may benefit from a calcium channel blocker because it may help in terms of their anginal symptoms. I think if somebody was an old age and a smoker and didn't have other medical issues, I still think that either an angiotensin receptor blocker, and I would use that instead of an ACE inhibitor just so I didn't cause a cough, or a calcium channel blocker would again be my top 2 choices.
Okay. So now coming to that about RAS blockade. So how do you see the comparison of efficacy of AC inhibitor versus ARB in terms of hypertension management as a class per se?
It is. I mean, I think there are, I mean, one thing I look at when I look at my drugs are how many are once a day versus twice a day, or even 3 times a day. And so I like once daily medications. So I would use a Ramipril over captopril in many cases, just because it will help compliance. And I will use a medicine like irbesartan or olmesartan rather than twice a day valsartan, and just to make life easier. I also do, when I can, if there is combination, I will try to combine those to make it easier. But I find that if I can get a once a day drug to somebody, that will make life a lot easier.
So yeah, that's a very, very important and practical point, improving the compliance of the patient, which is definitely a very, very crucial point. Another comment which has come from Dr. Uttam Jain, saying that hypertension essentially is a lifestyle disease. Then why not focus on lifestyle modification? Yes, my dear Dr. Jain, we totally agree. But whatever Dr. Serika is saying, it's all beyond lifestyle modification. So number 1, lifestyle modification is the basic factor, fundamental. There is no question, there is no substitute for it. So lifestyle modification is the crucial factor. And that is what he has also mentioned in the precision medicine, that there are so many factors, and the environment, like one is the environmental factors and one is the socio-cultural factors. And wherever there is a altered or abnormal behavioral pattern, and that needs to be modified. So we need to have a definitely lifestyle modification, which is absolutely important, and that would take care of the things. There is another question from Dr. Ashok Srivastav. What are the most common reasons for uncontrolled hypertension? Probably he wants to ask for the resistant hypertension.
So I go through a checklist in my mind, and I think it was reviewed very nicely at ACC 21. But I first really do talk about adherence and try to find out make sure somebody is really taking their medicines every day. We just in our hospital, we just got availability to a urine test that can test for many of the metabolites of the drugs. And so you can check for that. And some of these studies have done that as well, and found that even in people who very much say they're taking their medications. If you test their urine, they are not. And in some of these resistant hypertension studies, like the simplicity, like the one the Radiance one I just showed, they, again, if you were not on on all your medications, they gave you 3 medications up front, and a significant percentage, I think about 30–40% of patients, when they were taking that drug during the study, had normal blood pressure, even though they had been thought to have it on resistant hypertension beforehand. So adherence is one. Sleep, poor sleep, sleep apnea, strong indicators of risks of hypertension. Weight, as was mentioned, obesity, related to sleep apnea. But I tell somebody if they can lose 5 kilos, we'll probably be able to stop a blood pressure medicine in many cases. Non-steroidal anti-inflammatory will very much increase hypertension in patients. And so patients who are having chronic pain and taking non-steroidal anti-inflammatories will often be hypertensive. Alcohol, when you start getting more than 1 to 2 drinks a day, that will increase hypertension. And then I always ask about herbal, traditional, other supplemental agents that may have things like ephedra and other agents that may cause more vasoconstriction. And I very much would like you, I think lifestyle and diet, meditation, all of that can really help with behavior. But those are the checklist I go through. And if they're none of those and we still document somebody's high, then I do also start looking for secondary causes of hypertension, and the most common ones being or primary aldosteronism is the one that I think is probably most prevalent and unrecognized.
Right. Now, as you mentioned about that for evaluating for a secondary cause of hypertension. So let's talking about a young hypertensive. So is there any particular age below which you would definitely evaluate for hypertension? Because now we have been seeing a lot of young population. Even in fact, we are seeing the college going students who are presenting with. So is there any feature where you would suspect that this is just a 25-year or 22-year young guy and he's presenting with hypertension? So is there any cutoff point below which you would definitely investigate for secondary hypertension?
No, I mean, you bring up an important part. I mean, 30, 40 years ago, every adolescent should have their blood pressure checked at least once. But 30, 40 years ago, if you found that a young person under 25 had hypertension, there's a high likelihood that that was probably secondary cause, either from a hormonal imbalance or from fibromuscular dysplasia causing renal artery stenosis. And you would very much want to start your secondary cause. Unfortunately, with the obesity epidemic around the world, we're seeing a lot of 20, 25-year-olds who are presenting with hypertension, and it's a manifestation of metabolic syndrome, of prediabetes, of obesity and sleep apnea, in females of polycystic ovarian syndrome, all of these that need to have a much more multidisciplinary approach than just treating the hypertension. So I'd say that what's happening is that in my experience is that younger patients are having more of the hypertension that we thought happened when you got to your 50s. And so less likely to do the secondary workup when you have, if somebody's in front of you with prediabetes or diabetes and obesity.
Okay, so that is a very important message. Now coming to, you mentioned about the presented beautiful paper about the resistant hypertension and the data which you gave about the ultrasound renal denervation. Now I remembered we had earlier Simplicity hypertension trial where the results of renal denervation were discouraging. We're not so good in that. So what do you think which has led to this difference over here? Is it the technique or is it something else when we talk about the data or from the simplicity trial, which we have the data of renal denervation?
I think it's a very good question, and it teaches us. I think it's a lesson for everything, in terms of scientific discovery. That there is often and this happens in innovation. There is sort of the peak of excitement with the initial report that this is going to cure everything, and then you get a couple other studies that aren't so positive or negative, and you start getting into the sort of valley of despair, that this is nothing there and it was all just chance. And then I think some smart people went back and looked at those studies, and they said, I don't think we really identified the right patients. A lot of these patients probably didn't have resistant hypertension, and we were treating people who had just more mild hypertension. I think they also went back and said, if we look at the studies, the treatment became very different between the two arms. And in part, that was because they weren't always sham controlled. So you knew if you were in the medicine side and you knew if you were on the procedural side, even though it was randomized. And then thirdly, I think the technology has gotten better. And the early technology may not have been able to achieve as effective and safe a renal denervation as it seems like this newer technology that was studied does. And so then somebody said, okay, let's start doing some really well sham controlled trials that had much more strict inclusion and exclusion criteria and had much better procedures. And I think that's what we saw. And we've seen that in other places in cardiology, for example, with mitral clip procedures, where it's not as easy as it seems. Nor will renal denervation be an answer for the population health crisis, for which is hypertension. I mean, I think it's going to identify some patients where it may be very helpful, but I think that's going to be the tip of the pyramid, and we're going to be really continue to be leveraging the combination of hypertensive drugs that we have right now.
Okay. So good, as the things are evolving, and what you described was like initially it was like when the simplicity came, obviously it was people with a lot of excited, the things were different, and then suddenly we saw. So it was more like a honeymoon phase that got over, and the things came to baseline, and over a period of time, when people started maturing, they realized with the different techniques, things can be better off with that. Okay, there is another interesting question from Dr. Parikh from Kota. That is uncontrolled hypertension used synonym as refractory hypertension, or when do we use what terminology uncontrolled and refractory?
There are a lot of different terminologies, and the nomenclature here does get confusing. So I think even what we call high blood pressure or hypertension depends a little bit about what criteria. The way I think it's most useful to think about is uncontrolled hypertension is somebody whose blood pressure is not at goal. And that can be for a variety of reasons. They were just diagnosed, you're in the middle of titrating them, they're only taking one medicine, they didn't want to take anything. And so somebody is uncontrolled if they are not at goal. Refractory hypertension, I think, is now sort of more frequently termed resistant hypertension. And so I would use the word resistant hypertension for that. And that really is based on that definition that we saw in the ACC 21 presentation, but is also in all the guidelines. And it also comes up, there's often people talk about malignant hypertension, hypertensive emergencies, and some of those terms have also been moving, I'd say, a little bit to be more historical, and people are just talking about severe hypertension. And trying to simplify the name so we're all talking about the same categories. But that's a very good question.
Thank you. Another question from Dr. Renal Kanti Guha from Calcutta is asking, is there any advantage of L, N, and T type of calcium channel blocker over L and N type. Now you have got newer generation calcium channel blockers. So whether this blocking all three L, N, and T type has an advantage.
I know it's a good question, and what a lot of it comes down to, much of it is based on a lot of the pharmacokinetic type of features, and I think there are some of these newer agents that are able to block all of those, and the thought is, does that actually improve blood pressure reduction for because it may block aldosterone or some other pathways than the ones we use. I will say they tend not to be very available in the United States, so I tend not to use them, or they're costly. And so I tend to usually be with amlodipine, felodipine, and nifedipine XL are the three that I tend to focus on. I haven't seen, I've seen some studies on sort of small studies on some surrogate endpoints, but I haven't seen anything sort of in terms of, is it just better, is there better blood pressure reduction over the long term? Does that correlate into additional benefit beyond the blood pressure reduction because of those extra capacity or not? So I think there's more to learn, but I have not been incorporating that into my decision making these days.
Right. So the most important point over here, it is not necessary newer the drug, it will be more efficacious and will have a more advantage or benefit. In fact, it is also interpreted it costlier is the medicine doesn't mean that it is going to work better for blood pressure control, which we will have to keep it in mind also. So now with hypertension, we'll move on to the lipid questionnaires, and we'll start with one question which has come. What is the role of lipid lowering agent in hypertension? So we give, the meaning is, do we give a blanket statin therapy in all hypertensives?
Mm-hmm. It's it again brings that very important question when we that there are multiple factors that affect somebody's cardiovascular risk, and having one of them, having diabetes, having being a smoker, having elevated hypertension, all of these contribute to increasing the risk of cardiovascular disease, for which lipid lowering therapy is a cornerstone. And so there are very sort of quantitative ways of trying to decide that by using something like the SCORE risk from the European Heart Society, or one of the Framingham or the pooled cohort equation, which incorporates blood pressure into the SCORE. And if you're at a high enough risk, then it would recommend lipid lowering. In practice, what it means that honestly, anybody who's over 60 and has hypertension is going to be at high enough risk that they're probably going to benefit from lipid lowering therapy. And so I'm usually very early and aggressive in terms of starting statins in patients who have concurrent hypertension, especially when they start getting into their 60s.
Okay. So now what we have seen that, for example, in diabetes practice, that all the diabetologists are recommending anybody above the age of 40 years, no need to do lipid profile, and they need to be on statin therapy, irrespective of the lipid level. And maybe the time has come where we are seeing the conglomeration of multiple risk factors with hypertensive. And as you rightly said, we need to take a call at what point of time or what age this patient should be on a statin therapy. Another question which comes, what is the right time to prescribe omega-3 fatty acid supplements? Means, is there a threshold level of triglyceride or LDL at which we should start omega-3 on and above statin? From Dr. Uma Kumar.
A wonderful question for which there is still amazing amount of controversy. So I think, as you said, Professor, the first thing is you treat with a statin. And then I then turn my focus on the triglycerides, unless they are very high, meaning in the 800, 600, 800, 900 above, in which case I'm concerned they may be at risk for pancreatitis. But for most patients, when we talk about this, we're talking about people whose LDL may be well controlled now, in the less than 100 or less than 70, but their triglycerides will be in the 200 to 400 range. So a couple thoughts that I do is, first is you want to make sure it's a fasting sample, to make sure you have a fasting triglyceride. Secondly, diet and lifestyle is one of the most potent ways to lower triglycerides. And so if somebody can change their diet to have fewer simple carbohydrates, increase their vegetables, their complex carbohydrates and protein, and lose some weight, and it doesn't need to be a lot of weight, they can have a pretty dramatic effect on the triglycerides. If somebody has elevated triglycerides, even after doing that, or they're unsuccessful doing that, I've been very impressed by the results of the Reduce It trial that Dr. Deepak Bhatt presented a couple years ago with a icosapent ethyl, which is pure EPA of the omega-3s. And in a study, the Reduce It study, on top of statins, starting icosapent pentyl, significantly reduced cardiovascular death, MI, even when you started at triglycerides in the 150 range. And that pure EPA seemed to have the best data. There was another study called the Strength study that looked at a different omega-3 formulation, one that had both EPA and DHA, and that did not show any benefit at all. And there's been a lot of debate why one versus the other. I do think there probably is something about the component of the omega-3. EPA seems to be more cardioprotective than DHA. And it's also important to remember these were studies that used very high doses of omega-3, much higher than you could ever get from normal supplements. So it's the normal supplements have a harder time getting the triglycerides lower. And so I tend to do first, really try to work on the lifestyle and diet, and then when needed, use pharmaceutical grade omega-3 to be able to lower the triglycerides and the risk associated with that.
Yeah. So what has happened, omega-3 fatty acid journey has been like a real roller coaster journey in terms of results. You know, we have seen the lot of publications, and of course, before the Deepak Bhatt's paper came, there were journeys. So there was a time when strong recommendation came. Then again, one of the recommendation came from SEC. It has got no beneficial effect. After again improve IT, there was some data which was coming. So over a period of time, it has a really roller coaster journey for omega-3 fatty acids. But what you said is right. It is, we need to select the right component of it. It is not just a common blanket statement of the whole omega-3 fatty acid, and selection of right omega-3 fatty acids would be the very, very crucial point, and which can help, especially in hypertriglyceridemia. Another factor which you also pointed out, and that is very crucial, somebody who has got a significant hypertriglyceridemia, we must look out for secondary cause for it also. So somebody who has a severely uncontrolled diabetes, again, that would be the one of the cause for hypertriglyceridemia. Somebody who has a uncontrolled hypothyroidism, again, that would be additional cause, and we need to look for it, and that is very, very important. And you already covered, in fact, one question which has come from Dr. Rashmi Modwal from Jaipur: is there a role of diet in dyslipidemia, which you already mentioned? That is lifestyle modification, which includes the diet, physical activities, and other changes in the socio-cultural factors, which are going to play a very, very crucial role in tackling this hypertriglyceridemia. In fact, the paper which you presented about and mentioned about lipoprotein little a, in fact, we have seen the Asian Indians, they have a majority of them are having high LP little a, and which is not getting controlled with whatever standard therapies which we are giving it. So obviously we know HMG coenzyme reductase inhibitors like statins are not controlling LPA, so does even the ezetimibe also. And now you have shown the newer therapy options which would be definitely would be there. So I think we have covered most of the questions pertinent to the lipids, which is beautifully covered over here. So now for the benefit of our patients, I would just take a few key takeaways, whatever Dr. Sirika has stated, and which is so much important. Now, he mentioned the importance of control of hypertension, which is a very, very crucial aspect. And in fact, from the sprint trial onwards, we have seen the results, that is, that reduction in hypertension, lower the better, we can reduce primary and secondary cardiovascular events significantly. In fact, the data which he presented, by reduction of 5 millimeters of systolic blood pressure, we can reduce 10% cardiovascular events. And that is a huge number. When you translate it into a real world scenario, it will really make a lot of important impact on it. Sir nicely mentioned about, presented the paper on the tips and tricks of managing resistant hypertension, and talking about the Radiance hypertension trial study, where I'm sure over a period of time we will see the future where ultrasound guided renal denervation techniques, which will be helpful in a certain subset of patients of resistant hypertension, which we are going to see over a period of time. He also mentioned about the precision medicine, where individualization of therapy is a very crucial factor, knowing that hypertension is a polygenic disease. So we need to have behavioral and environmental factors which needs to be changed and adapted to get a better outcome also. So hypertension is one thing which is so crucial, so important, and so much still neglected. In fact, sir, we feel that in India, we have seen there is a standard rule of 50. That means those who are hypertensive, only 50% have been diagnosed. Those who have been diagnosed, out of them, only 50% are on medication. And those who are on medication, out of which only 50% are controlled. That means if we take a total subset of population of hypertension, only 12.5% who are taking medicine, taking regular medicine, and are controlled. So that's a definitely a poor state of affair, which we can definitely create more awareness and improvise on it. Coming to lipids, sir has beautifully presented all the data, and obviously reduction in 1 millimoles of LDL, that means almost 38 to 40 milligram per DL of LDL cholesterol, will reduce the cardiovascular events by 30%. And that is a huge number which we are looking at. So our basic target or primary aim when we look at the lipid control is to reduce the atherosclerotic risk by reducing LDL. In fact, when statins were used, and in fact, when the US FDA approved the statin, it was just merely for LDL reduction. After its approval, people started realizing it is not just LDL reduction, but it has a pleiotropic benefits which were learned later on. And that is how we see there is a significant impact when we are looking at atherosclerosis. The newer therapies, which Professor Sirika has mentioned, and of which inclisiran, which is a once in 6 months, it seems to be a really, really promising agent. One shot every 6 months, and probably it is definitely going to impact. We don't know what will be the cost when it comes, and that is going to be obviously inhibitory factor, but yes, for a certain subset of patients, or there are patients who are intolerant to statins, there would be definitely some hopes that we have got something else. You also mentioned about omega-3 fatty acids, which are the all omega-3 fatty acids are not similar in physiochemical and biochemical properties, and we need to select the right one for the right indications also. So I really admire, sir, the way you presented in the crisp way and given the summary of the right from basics to near therapies in hypertension and lipids. So we are really thankful for that lovely presentation and discussion. So before we I hand over to Dr. Samir, any few tips, two lines for hypertension or lipids you want to give to our delegates across the country? And we have a pan-India, a large population of cardiologists and internists who are listening to you. A message from your end, sir.
I could not improve on your summary of the most important points. Our numbers in the United States are not far from the 50% rule that you did. So I would again say the most important thing is to screen, educate, identify, and then treat. And I think we just have to, and it's only through those efforts that we will be able to get control.
Thank you. I would now request Dr. Samir Muchala to take the further proceedings. Samir, please.
Thank you, Dr. Ketan Mehta. I think today we had great deliberations with respect to various aspects of hypertension as well as dyslipidemia, may it be resistant hypertension, importance of medicine adherence, nocturnal blood pressure management, or lipoprotein A, non-statin therapy. I think these are the basic things which we see in our clinical practice. And I should thank our speaker, Dr. Benjamin Sirica, who has joined us all the way from the United States for a powerful delivery of path-breaking recent updates in dyslipidemia and hypertension. My heartfelt thanks also goes to Dr. Ketan Mehta, as team moderator, who as always has been effective in navigating the discussion in a manner that the key messages were percolated to our esteemed delegates. I'm more than happy to announce that we had 4,250 physicians across India who have attended today's webinar. So thank you all for sparing your precious time for attending today's live webinar. And let us all stay safe, stay healthy, and special thanks for staying besides our Indian patients right now who are currently reeling under the COVID scare. Thank you very much, Dr. Sireka. Thanks, Dr. Ketan Mehta, and thanks to all the delegates again. And may God bless all of us. Thank you.
Thank you. Thank you. Bye-bye.